Welcome you all to a weekly session of Oncology Club. We are now discussing the real-life case discussion on breast cancer series. Today we'll be discussing fertility, breast cancer, and pregnancy. A bit different type of topics, but hopefully we can create some interest among you. So let me introduce our today's faculties. We have two foreign faculties here, Dr. John Conibeer, who is the consultant oncologist at Barts NHS Trust UK, and Dr. S.K. Farid Ahmed, who is oncoplastic breast surgeon working in Wickham Hospital, and also he is working as a consultant surgeon in Labit Cancer Hospital and BRB Hospital, because he is a person having side of two coin, one born in Bangladesh, working in UK. Welcome to both of you. John will be joining with us. And now today we have a special guest with us is Professor Dr. Mariam Faruqi Shati. My apology for the mistake in her name spelling. The ever smiling face that I saw in gynecology, and who has been taking interest in fertility preservation in the country. But very interestingly, for so many years, she has been trying to work on oncofertility, at least start talking on it. And recently, they have launched a society, Fertility Preservation Society of Bangladesh, and she's the Secretary General of that society. And we have a young oncologist, Dr. Mohammad Abdul Mannan, who is the junior consultant. He's the Department of Clinical Oncology, Labit Cancer Hospital and Super Specialty. We have a cancer care and super specialty hospital. So, customarily, we start our program with a comment from our president, Professor M.A. Hai, who is the patron program and also is the president of Oncology Club. Now, I would like to request our president, Professor M.A. Hai, sir, to formally start the program.
Thank you, Kamal. Bismillahirrahmanirrahim. We are we'll be listening to our consultants. One is Dr. Mariam Faruqi Shati. I'm very happy that she has joined. She took time, give time to us. And Dr. Mannan, foreign faculty, Dr. Farid Ahmed. Local come foreign. He will be joining recently. So without delay, I think we should start today's our subject discussion is fertility, breast cancer, and pregnancy. A new subject for us, and Sati is doing work on over this for a very long time. We should be happy to listen from her. I think we will learn many things from her. Over to you, Kamal.
Thank you, sir. So the program will be totally 60 minutes. There will be no lectures. It will be more a problem-based discussion, and we will try to take some opinion from the participants, and then we will discuss with some evidence. And we are requesting everybody to join in the poll, because the fastest respondent will be giving award. So first, Tania, show the poll question. Question number 1. A 25 years old lady, premenopausal CF breast cancer, T2N1M0, IDC grade 3, TNBC T67 30%, BRCA and family history positive, plan for NSCT with AC, Paclitaxel and carboplatin. What special counseling you will do considering her age? Frequent follow-up, to do BRCA test for other family members, not to get married, or fertility preservation. We have 24, only 4 out of 16%. We are requesting more participants to join. I can say 56% have joined. I think Tania will stop the poll. So we can see that 1 out of 17 in favor of doing frequent follow-up, 7 out of 17 is suggesting to do BRCA test for other families, and 13 out of 17 is in favor of discussing fertility preservation considering her age. So, coming back to the discussion, so this is a paper published by the Italian colleagues that they said is prefer study. They have taken a cohort of 223 patients from November 12 to December 2020. And the age range of this cohort was 38 years, median age ranging from 24 to 45. And they were all early breast cancer patients, were candidate for neoadjuvant chemotherapy. And they were discussed about fertility preservation by GnRH agonist. And we can look at the curve that in the age range of 41 to 45, 90% of the candidate accepted the fertility preservation option. And below the age of 40, 95% accepted the option. And in the total cohort, 159, around 71% was in the age of less than 40 years. And those who didn't take the participation in the fertility preservation, the reason was fear of delaying the anti-cancer treatment. Some of them were thinking that it is contraindicated to the procedure of the treatment, and some of them were lack of interest in future childbearing. So I come to our junior most faculty, Dr. Manna. How often the patient express concern about fertility preservation to you? Manna.
Thank you, sir. Actually, you know that at the last phase of the treatment, patient came to us for radiotherapy in the breast, whole breast or in the chest wall. At that time, all the patients either completed their neoadjuvant or adjuvant chemotherapy. So we can divide most of the patients. I have talked to them, so they give out the mixed type of reaction. One group of said that doctor didn't consult with them or discuss with them about the fertility issues. Other group was there. Doctor actually discussed with them, but they are not interested to do. And other group said that they willingly wants to preserve the fertility, but doctors actually don't interested to do. So there is reaction, what I say. So in that scenario, actually, when the patient came to us and want to consult and want to know about can they become pregnant after the completion of the treatment? So it's a really hard question to answer, actually. So in that scenario, we have to plan it early and plan it very early so that we can preserve the fertility if there is a serious issue regarding the family completeness or not.
Thank you, Manu. So, Farid, when you are practicing in UK, when you have a lady, premenopausal lady, or somebody around 40, what is the practice of your center in UK?
Thank you. We would normally go through all the risk assessments and everything. And if patient hasn't got any children, and patient is quite young and would like to have children in the future, or somebody who's got children but would like to have more. So we would refer, while the patient is getting referral to oncologist, at the same time, we would refer her to fertility clinic. And the fertility specialist will review her and initiate some treatment, for example, like egg harvesting or other means. And then it takes a little bit, for a week or 10 days or something like that, maybe a little bit long. And then by the time, oncologists can then initiate their treatment. So we would consider referring this person to fertility clinic. Thank you.
So Farid, I mean, when you are in UK, any patient who is a candidate, you straight away refer her to the fertility clinic before starting the active treatment.
Not straight away, but we discuss it, and if patient wants it,
and if they agree,
yes, we will.
So let me tell you that flip the coin. When you are in Bangladesh, same patient coming to your clinic, what you are doing here?
Usually that consultation, the counseling part, I do that as well. So that takes extra, which is why my consultation goes about 45 minutes. And if patient agrees, especially younger patients which are come across, they agree. And when they go, when they found out after the consultation with the fertility specialist that there is a bit of time gap, they get scared. And then often they come back to me saying, I don't want to wait. just get on with the medications, refer me to oncologist. And it's very difficult, very, very difficult. But I think we have to continue to keep pressing and to show them the right path and the right advice. Thank you.
So we can understand from the same person when sitting in UK counseling the patient, and when the same person sitting in Bangladesh facing some challenge. So now let me move to Dr. Mariam Faruqi Shati, who is a known person working on fertility preservation, infertility, rather, I will say, a common term in our country. But now she has started, I will say, the campaign for fertility preservation, especially oncofertility. So, Madam, with your experience, especially breast cancer or young cancer patient, what is your experience?
Thank you very much. Now, only few patients come in my this infertility practicing program. I found only few cases. I don't know why they are not. I think only few cases in my practical, maybe 3, 4 I can count. Patient came for fertility or after the effect of chemotherapy, radiotherapy for fertility. They have become infertile, for fertility. But I think so. This is our challenge because we want to aware the people, aware the patient, aware the parents and husbands. She may overcome this cancer situation, and so she can lead a normal reproductive life. So this is a challenge. The patient should come beforehand. Dr. Farid will send the patient. Dr. Kamal must send the patient to me, so I can take. If Kamal, if any oncologist counsel and then it will be a better. So challenge is to make them aware. So acceptance will be better. Otherwise, if you send directly, they are confused, and someone will say, "Oh, you must get rid of the cancer." Then you will take treatment for fertility. But we want to show her that there are paths, there are ways, so you can lead your normal family life. And again, after referring, sometimes we don't have the link. So if you refer me, if you give a call, or she knows that you are taking the care of the patient, then they will get the trust with you. So they will come. These are the challenges that we usually face with. And most important challenge is they come after their eggs are finished. They come with high FSH level, they are amenorrheic, their ovaries are destroyed, their uterus not working, then they come to us. So it's very much difficult for us to get them, to make them understand and make them pregnant. It's difficult. So I think if before starting any treatment, if patient is suitable for fertility preservation, you must send us, or you must discuss, or we can discuss in a teamwork, so that patient will get trust. They will come to us. They will know. They will be aware. They get rid of the fear of cancer.
Thank you, Madam. So we understand that you till now the referral is not great, and you think that we need to aware, the doctors need to be aware, patients need to be aware, and then we can go ahead combinedly. So next question, Madam, what are the facilities for fertility preservation for female is available in our country at this moment?
Yes, we were in infertility centers, fertility where we are practicing. We are doing the oocyte preservation, embryo preservation, sperm preservation for many years. So out of 4 or 5 options like GnRH, we can suppress by GnRH agonist, it is available. Oocyte, stimulating the ovaries and getting the oocyte out and harvesting eggs, and this is available. Again, if she had a partner, we can make embryo of the oocytes and we can preserve. So, and semen is preservation is going on from the for many years. So we have out of 5 options, only ovarian cortical tissue preservation that we are facing now challenges, because the media is expensive, and to make them understand patient, and to collect the ovarian cortex and small surgery, and then again preserving this is a big, now I think it's a big problem now. But this out of 5 or 6 options, we have majority of the treatment options we can give. But I think main is patient should come. They should know they should come.
Thank you, madam. So we understand that at least for the oocyte preservation or the embryo preservation, you need at least 2 weeks time, if I'm not wrong.
Yes.
So
yes,
for it,
for oocyte less time, but for yes, more or less 2 weeks. I will for giving stimulation, collecting. We can do twice stimulation in this 2 weeks period, and then we can collect.
so,
And if you give 4 weeks time, that will be much better.
So I mean, how dependable these methods are? Somebody said, okay, I want to preserve my oocytes or embryo. So am I 100% sure that if something goes wrong, I'm going to get the baby? How much we can give them guarantee about having a baby?
Guarantee in the every process we cannot give 100% guarantee. We collection, the quality of the egg, then making them with slow freezing, giving cryopreservation, then keeping them, and then again making them thawing, and there is in every steps there is some loss of the egg. So about around 50% we said them, and before doing this, we always counsel them that 100% recovery is not possible, but 50%. So you should keep this around 50%.
What is the best method, madam? What is the, among all the options you said, to you, what is the best method? Can be
for male,
or
semen
maybe
is
we can see in
best.
our country context, what is the best method?
Yes, for semen is the best, very much easier for male, and for female, embryo is the best, and it is tried for many of the years, embryo cryopreservation, if there is partner or husband, and if not husband, then oocyte, then cortical tissue.
Thank you, madam. For it, my question is, we understand that it takes 2 to 4 weeks time, and I'm sure this time requirements are universal because this is a process demanding, the time demands for the process. So we saw that the patients are very concerned about the delay. In the paper that we discussed, they are also saying that Italy, they refused because of the delay. Are you facing this challenge in UK when you are discussing that referring a patient to a fertility clinic, they're coming back, no doctor, I'm not going to wait for 4 weeks. We want to start a treatment, neoadjuvant chemotherapy.
Thank you. In my 25 years experience in UK, I have rarely come across patient refusing to go ahead with the fertility treatment because of the fear of delay in treatment. Maybe rarely few exceptions, but that is the fact in my experience. Thank you.
So thank you for it. What I understand that even in Italian paper, the percentage of refusal is very low. We can say less than 5%, around 5%. So it depends on availability and also the counseling. And we need to change the mindset of the patient and the doctors, and hopefully, inshallah, this will change. So let's look at the ESMO guideline. The ESMO is telling that oocyte and embryo cryopreservation, ovarian tissue cryopreservation, ovarian transposition, that is not for this case, and medical gonadotropin. But I have picked 2 interesting recommendations that all cancer patients of reproductive should receive complete oncofertility counseling as early as possible in the treatment planning process, irrespective of the type and stage of disease. And the recommendation level is A. And as there is no absolute threshold of exposure to anti-cancer therapies that determines gonadal failure and infertility, every patient should be considered as being at potential risk of developing treatment-related gonadotoxicity. So there are 5 recommendations, but I have picked these 2 intentionally because we see that each and every patient need the counseling, and irrespective of selection of drug and modality, even minimum risk, we should go for fertility preservation. So we could move to our next question, Tanya. Which factor doesn't create impact on fertility in a breast cancer patient? Age, chemotherapy drug, dose of the drug, family history, BRCA positivity. Which factor does not create impact on fertility in a breast cancer patient? only 18% has joined. 25. Hi, John, welcome. So, Tanya, I think we can stop. Okay. So we can see that 48%, 14 out of 29 has participated. One answer, 2 out of 14 is age. Nobody in favor of chemotherapy for sure. 1 in favor of dose, doesn't create an impact. 6 out of 14 in favor of family history. 8 out of 14 is in favor of BRCA positivity. So this is a paper published in 2021. It is an editorial, JT et al. How I perform fertility preservation in breast cancer. And they have shown that the age, drugs, and the dose, because age of the patient, when it is less than 40 and above 40, it creates an impact. And definitely there are some drugs which cause more infertility. There are low risk and some unknown. And definitely the dose, number more the cycle, higher the chance of infertility. So, John, you have joined just now. Let me bother you first. When is a young lady, when you are going for a selection of a neoadjuvant chemotherapy drug, do you select some, you avoid some drug or make some special decision because she's a young lady that this may be suitable? Any gameplay for selection of drug? John?
Personally, I don't know. I use the same drugs irrespective of premenopausal, postmenopausal status, assuming fit well. So that doesn't, I select it on the basis of their breast cancer rather than their menopausal status.
Farid, any comment? In your clinic, is there any, they have any special choice that do, that, oh, we don't use this drug, or we use this drug, any there, or?
Are you just talking about neoadjuvant chemo only?
Yeah, neoadjuvant, only neoadjuvant.
That's fine. No, nothing additional from John. Thanks.
Okay. So we understand that even we wish, we don't have much option to tailor the selection of drug to offer a security for the fertility in neoadjuvant setup. So the answer, the message is that we have no other option than going for fertility preservation in a candidate. We don't have any option, even knowing that drug and dose is the culprit for doing this, but we cannot create any modification there. So we need to, only option is that we need to discuss the fertility preservation and take the help of our consultant. So our next question, Tanya. 30 years old lady, hormone receptor positive, early stage breast cancer, T1N0, grade 1. Surgery done, radiotherapy given, and after radiotherapy, plan was to give her endocrine therapy only. But the lady didn't have a baby, she wants a baby. So what will you do? You will say, okay, you go for pregnancy, don't take any endocrine therapy because we know endocrine therapy has some effect on the baby. Or you say pregnancy after 5 years of endocrine therapy, or after 10 years of therapy, or you go take endocrine therapy for 18 to 24 months and then take a baby. We stop it here. So majority was in favor of D, 17 out of 19, and 2 out of 19 pregnancy after 5 years. Well, now coming to Mannan, Dr. Mannan, if the patient is in
Yes,
your
sir.
clinic She wants a baby, and we discussed that taking hormone is detrimental for the baby. So,
Yes, sir.
baby or mother, which life is important? What will be your option?
Yes, sir. I need both. Actually, without the baby, mother is actually incomplete. So I need both. So I'd go for the at least 1.5 to 2 years of hormone therapy, and then we can pause and let she tried for the pregnancy. Hopefully, she can conceive. After that, I can switch over to rest of the 3 years or extended therapy, whichever is suitable for her. Thank you, sir.
So, John, what is your practice there in this type of situation?
I would, so in the UK as well, if we're thinking of using endocrine therapy, I would probably send them to see a fertility specialist first as well, because endocrine therapy can influence pregnancy. So that's also a potential risk to consider. But typically, I normally give them 18 to 24 months and then pause and let them get pregnant. I appreciate in this case, though, the perceived benefits of endocrine therapy are probably very low for a grade 1 tiny tumor. So I think there'd be quite a big discussion there in terms of how strongly the patient feels about pregnancy. But I think hopefully that answers the question.
Yeah, John, so I understand that you need to discuss the issue. Well, Farid, yeah, coming to you. What is your practice?
Thank you. I just wanted to add one thing, what John have said, which is this is what we practice as well. But the thing we would recommend is once they have stopped taking tamoxifen 18 to 24 months after taking adjuvant treatment, we advise them take 3 months precaution, other measures, and then start truly try for conceiving 3 months after stopping because of the long drug half-life. And that is the recommendation of the Royal College of Obstetrics and Gynecologists as well. So we need to be a little bit mindful about that part. Thank you.
Thank you, Farid, for bringing up the details. So what John was telling that this is a tiny tumor with grade 1. The role of endocrine therapy is not that much important like a high-risk group, but still there is a need. So what we see that 18 to 24 months, and what Farid said, very important, that we need to gap of 3 months after stopping the treatment. Then we can try for the pregnancy, and end of the pregnancy, they can restart and complete the scheduled course, whether it was 5 years or 7 years, whatever it is, and the selection. John, if there is a question, if it's a bit high risk group, John, so it is not this grade 3, we will change the scenario.
If it's high risk group, again, normally the first couple of years, if they really want to have a baby, often patients will not want to take anything at all, in my experience. And so if you can encourage them with a high risk tumor to take 2 years before proceeding to a planned pregnancy, I think that is often, a sort of something that you can reach with brokering with your patient. Compromise is the word I'm looking for. Yeah.
Thank you, John.
Kamal, can I ask?
Yes,
in high risk case, where in stage 4 grade high, will she go for fertility preservation treatment options? Because her life is at stake. So we usually, before giving any fertility preservation advices, we take advice from you, whether this is an advanced case or whether it's a low risk case. Then we'll go, isn't it?
Yeah, this is a discussion. What John was telling, we need to discuss with her the risk of the disease and also the chance of the baby. If she is keen to have the baby, then in between method is to go for a endocrine therapy for 1.5 to 2 years, give a gap of 3 months. This is not a total foolproof solution, but something that we are doing. So till now, there is no consensus paper on it, but we are waiting for the positive trial. That is a multi-country, multi-center trial, 116 centers in 20 countries in 4 continents till now they have recruited 518 patients, and they are waiting for the result. They have taken the median duration of endocrine therapy is 23 months, and then they have gone for pregnancy, and now they are going to result. So unless this abstract was presented very recently in this San Antonio Breast Cancer Conference in 2021 February, and there they have not shown the result, they have shown the participation, and we are waiting for this positive trial. And once the positive trial result is published, then only we can have a robust data to recommend. But till now, what Farid and John was telling, that is the recommendation that they are practicing in NHS, because this is a situation sometimes we encounter here, and sometimes we feel confused what to do. So that's why we intentionally brought this issue. So now going to question number 4. Tanya, question number 4. What is not true for use of GnRH agonist during chemotherapy among premenopausal women for preservation of ovarian function and fertility? Fertility outcome rate is acceptable. Preservation of ovarian function rate is acceptable. Not safe for mother, safe for baby. Which one is wrong? Which statement is wrong? When you use this GnRH agonist as a method among these 4 statements, which statement is wrong? So we stop it here, Tanya. We have 11 responded from 23, 26, 42%, and there was a fair distribution. 2 out of 11, fertility outcome rate is acceptable. They don't agree. 3 out of 11, they think that ovarian function rate is acceptable. They don't think it is a correct answer. 5 out of 11 thinks that it is not safe for mother is wrong. They think it is safe for mother. And 3 out of 11 thinks safe for baby is not correct. They think that it is not safe for baby. So my question to Mannan, do you have any experience of using GnRH agonist for fertility preservation? Have you seen or have you practiced?
No, sir. I actually didn't. I actually seen, but I didn't practice yet. But there is some use.
Practically, did you practically saw a patient?
Yes, sir. I saw it. I saw it where there is use of the GnRH analog. It's, actually 2 weeks before the first cycle of chemotherapy. One oncologist is already practiced it. So I have seen it.
You saw that they give just 1 cycle. I mean, prior to the starting
Prior
of
to the chemotherapy, they give 1 cycle of GnRH analog.
So how long do you think it should continue? Up to the end of chemotherapy or 1 month? I mean, what is your idea about the duration of this GnRH agonist?
Definitely, it should continue throughout the chemotherapy, so that we can clearly suppress the ovarian function. So that after chemotherapy, we can pull out the ovum and healthy oocyte. So we should continue it.
Thank you, Mannan. So, madam, what should practice here? I mean, what is your recommendation when we should start and how long we should continue?
If there is no other options and time is less, you can start with gonadotropin GnRH agonist. We can start with, and along with chemo you can give, and so you can just to. But in that case, we are not taking the oocyte and not taking the embryos. Just to another option. First option is to suppress FSH-LH by giving GnRH agonist, so the eggs will not be destroyed by the chemotherapeutic drugs.
Yes. So you are suggesting that we should start along with the chemotherapy.
Yes, if there is no other option.
So John, I mean, only GnRH agonist are you practicing, or it is a combined in your country or practice? Is there any group they're taking only this, no preservation?
So our routine practice is when we meet the patients initially and talk about family planning, we'll then refer them to see a fertility specialist, for egg harvesting. In terms of my use of GHRH, I do use it in my premenopausal patients. And in fact, we've had a discussion recently, week before last, about variation in practice across consultants in their use of GHRH in, premenopausal triple negative breast cancer patients, for instance. Some do, some don't use it. I would for ovarian preservation. I think the evidence is the meta-analyses that favour it. There's controversy about what's been included and what hasn't in terms of trials, positive trials versus less positive trials. But I do. In terms of duration, it then feeds into what you're going to do in the adjuvant setting in terms of their endocrine therapy. And so if you're planning to use ovarian suppression and an AI, I just continue it through that until we come to that potential break point for them to get pregnant. Does that answer your question, Kamal?
Yeah, very much. Farid, question to you. In your center, when you are you using monthly or 3 monthly? There's a tricky issues for 3 monthly and 1 monthly.
3 monthly.
3 monthly. John? Because there is a group.
So I
I
use monthly because the license isn't 3 monthly. So again, when they move out into the general practice, my experience is that GPs then just give it 3 monthly. But when I'm prescribing it, I stick to the license, which is monthly Zoladex. I'm sure 3 monthly is fine.
So, madam, my question to you, that there is a group, they believe that when we use 3 monthly, at the end of 2 months or 2.5 months, there is a hormone surge. So the level may not be like that. I mean, that is a concern when you use more ovarian suppression for AI, not here. When you are using as ovarian suppression for treatment, we are very strict bound to monthly because we don't want the fluctuation. But for this suppression, is 3 monthly safe or we need to do 1 month?
Now, there are two types of dose, 3.6, I think, monthly, and 7.5, I think, 3 monthly. So, or 11 point something.
11.2.
But after 1 or 2nd month, patient may suffer from like menopausal symptoms, hot flush and something. In that case, you have to give her always advec therapy, like with calcium, after consulting with estrogen or progesterone, if it is not estrogen receptor sensitive tumor, ER positive tumor. So I think every monthly will be better.
Okay, thank you, madam. So there is 2 schools of thought. We can go for 3 monthly and monthly. And for preservation, this is not a big issue, but when we are using AI, then this is an issue. So this was the meta-analysis that John was referring. So definitely I put the meta-analysis which in favor. Tanya, can you please make silent the one participant? So this is a meta-analysis comprising 5 trials and 873 patients. And then you can see that this from 73 patient, 14.1% had premature ovarian insufficiency when they were in GnRH agonist group. And compared in the control group, this was 30.9%. So there was around 50% less, and the p-value is significant. And if you look at the pregnancy rate, out of the 359, 37, 10.3% became pregnant with GnRH agonist. In the control group, only 5%, 20 out of 367 became pregnant. So this was the meta-analysis that John was referring, that is in giving in favor of GnRH agonist. And if you look at the safety data, you can see that both ER positive and ER negative, DFS and OS, this is equally safe with the control group. So we can say that it is safe. And chances of pregnancy, as I said, that if you look at the paper published in Journal of Clinical Oncology 2021, actually ahead of print. It was presented by Lambertini, and they have shown that the breast cancer are the survivor, the second only to cervical cancer patient in terms of low likelihood to have a subsequent pregnancy. Even if you look at the all cancer groups, so breast cancer is the second after the cervical cancer. So we are here. And if you look at the pregnancy in breast cancer, whether it is a risk for the mother, there was a question in the young breast cancer conference, and both in BRCA mutated and overall, majority was disagreeing that pregnancy is a risk for breast cancer survivor. It was 55% to 70% was against, and the acceptance or agreeing percent was 12 to 15%, and 30 to 18% was in neutral, and this answer was significant. So from this poll, we can say that the majority of the expert for the young breast cancer treatment group was in favor that this is not a risky venture to become pregnant for a breast cancer survivor for their subsequent recurrence of breast cancer, both in BRCA positive and non-positive group. And in this forest plot, you can also see that DFS and OS both is in favor, the diamond is in favor. So we can say that the maternal safety is not at stake. Question is whether the baby is safe. Again, you can see that they have done a meta-analysis, and in this forest plot, they've included 9 records, and there was 3,240 breast cancer patients among so many general population they have taken from this record. They have screened out the data, and they have shown that cesarean section was the majority of the delivery outcome, and congenital anomalies was not that much important compared to the outcome. So when we are scared about baby safety, it is rather we have seen the low birth weight, preterm, and a small or gestational. These were significant. P-value was significant, but the congenital anomalies, which is the main concern, the P-value was not significant. So we can say that with this preservation, there is a safety for the baby also. So we have discussed this. Now we are at the last question that Tanya give the 5th question. Which statement is wrong? Young patients are interested for fertility preservation. Minority of them attempt for fertility. Success rate of fertility is low. Shuman, can you please mention that which message you are regarding the safety or the baby or the mother?
Regarding the mother.
Mother safety is not also issue. This both the paper have shown both the baby and mother is safe. There is nothing to be concerned about the safety of the mother and the baby, because the risk of recurrence of breast cancer becoming pregnant in the survivor is not higher. Majority was against it. So we can, I think, Tanya, we can stop it now. We have 13 out of 24. 1 out of 13 things that young patients are interested for fertility preservation is wrong. 7 out of 13 think minority of them attempt for fertility, wrong. And 8 out of 13 think success rate of fertility is low. So this was that I wanted to make it in a tricky way that this is a paper published in 2020 in December on a cohort of 1,026 patients eligible for fertility. And if you look that out of 1026, when they were discussed, only 36% were interested for fertility preservation. And among these 36%, 34% attempted for pregnancy. But interestingly, 71% of them became pregnant. So we can say that young people are interested, but not the majority. And who are interested, a good number of them are not attempting for pregnancy, but when they are taking an attempt, majority are 70% plus are becoming pregnant. So we can see that many women remain interested in future fertility in 4 years after breast cancer diagnosis, indicating that longitudinal fertility discussion are needed. Although a minority of these interested having children attempted to become pregnant in first 5 years, most who attempted conceive did so and have live birth. So this is a practical issue that we need to keep on doing this discussion. Only one discussion is not enough on the whole course of time, because they may give up and we should not give up. So now in 2021, this was an editorial. Again, I go back to the editorial published in 2021, that newly diagnosed breast cancer in premenopausal women, we need to counsel the patient about gonadotoxicity risk, if they desire for preserving fertility, if the time is more than 2 weeks time, and preferably at less than 40 years, ovarian stimulation followed by oocyte and embryo cryopreservation. If the time is less than 2 weeks, then ovarian tissue cryopreservation. And either of the two, they can go for GnRH agonist during the chemotherapy. And if they want to preserve the ovarian function only, then also we can go for GnRH agonist during chemotherapy. And counseling about adequate contraception during active treatment and follow-up is also important. So this is where I want to stop. Next week, we will have a breast cancer surgery, all the question of an oncologist. We will have two surgeons, Dr. Farid and Dr. Zakirullah, along with Dr. John Conibier and Dr. Mustafa Aziz Shuman will moderate the session. Thanks to our academic partner, Roche, for supporting us. And I think we have some time in hand. If any of the faculty want to make some comments, I would appreciate. Yes, Farid.
Thank you very much. Very interesting topics and time needed. I wanted to just touch upon pregnancy-associated breast cancer. Were we supposed to discuss this today, or was it supposed to be in a different date? Because we concentrated mostly on fertility, but breast cancer in pregnancy or pregnancy-associated breast cancer, I thought we might have.
No, we will discuss it separate. Today we wanted that fertility and pregnancy during this.
That's fine. That's fine. Thank you.
So Shuman was asking about the price. Madam, we know this platform is not a fair area for, but just can we give some idea that for preservation, I mean, if somebody wants a budget, what type of budget is required? He was always knocking me with the price of this preservation.
For oocyte embryo preservation, where I work, first, I will tell about the BDT, Bangladesh Taka, 40,000, 40 to 60,000 first to cryo or preserve, and then every year to keep these in cryo can per month 10 or 10 to 20,000, it varies. So initially 60,000, and then you can make it 20,000 per year to keep the to preserve. So how long every year she has to, or she has to renew this?
But after the treatment, how I know that we need to keep the embryo, or she is okay? I mean, she need to continue the preservation on. Is there any way to understand the treatment is over? She comes to you, madam, I want to test. Everything is fine. Do I need to keep the ball rolling for the preservation, or I can go for normal? Is there any way to understand that?
Yeah, yes, we can. We see whether she is amenorrheic, whether FSH is high, or test for AMH and anterior follicular count, and AMH will indicate whether she has any reserve in the ovary. If she is okay after 2 years, if we found her normal period started and anterior AMH is well, so we can try without using that oocyte or embryo, we can try with her own. If it fails, then we will go for IVF or other treatment. But, Dr. Kamal, do you remember you sent one patient? She was breast cancer patient. She came from Narayanganj and she was amenorrheic. FSH was very high. We gradually give her medicines. Only oral contraceptive will make her FSH down. Then we stimulate her. Only 1 or 2 eggs were there, and she became pregnant after IVF treatment. And in this pandemic, she delivered. She came from Narayanganj. We were scared because in Narayanganj there was so many corona, too many crowd of corona. So she came. We did the cesarean section, and it's our. We were very much lucky, and she was also lucky.
So, madam, this type of encouragement will encourage us to think for, more in future. So, John, any comment? Because this is very interesting for our country perspective. Unfortunately, this is not a very good practice, but we need to discuss it more frequently.
I think the key thing is when you've been diagnosed with breast cancer and you're a young woman, your perspective on life is likely to change dramatically overnight. And many patients I meet, they just want to start treatment ASAP, and I think it's our role really to educate them and reassure them that thinking for the future is important, because if you plow on and you don't do something to preserve your fertility, you may regret it later. And so taking time to think about it is really important, and less haste, more consideration. So
thanks, John. That is our responsibility. We need to bring on the table. I see still I have 3 minutes time. I have some senior faculties. Professor Parveen Banu madam is there. Madam, very quick comments. Can you make a very quick comments? Madam, are you there? Dr. Parveen Akhtar Banu.
Thank you very much. Thank you very much, Dr. Kamal. It is a very nice topic to discuss. We face a lot of time, young patients and fertility preservation issues. Usually we don't talk much about this, but we should. And we should take care of this side of the patient fertility issues. Yeah. Thank you very much.
Thank you, madam. So I think we are almost at the end. So what chemotherapy drug contraindicated in a city? There is no drug contraindicated, Dr. Baniul. We have discussed that whatever is indicated, we need to give, and we cannot just tailor the drug of NSCT for fertility preservation. That already discussed. We will know that this drug is more risky, and whatever the risk level of risk, we need to go for fertility preservation. So we need to take the support from somebody like Dr. Muriam Faruqi for fertility preservation. That is our responsibility. We cannot tailor the drug. So now I think we can finish the session. Sir, would you formally finish it? Oh, before that, sir, sorry. Last week, poll winner, Tanya. So last week, Shahida Alam, Suryana Sultana, Saiful Alam Kajol. Congratulations to all the three. And hopefully next week we will know the winner of today's poll. So, sir, can you please conclude for me?
Okay, thank you, Kamal. Very nice discussion, very nice. Anything if think, but people are not very much aware. We have to be aware ourselves, we have to be aware of people, we have to give them the right direction. Thank you all very much. My special thanks to Dr. Sathi.
Thank you, sir.
And thanks to Dr. John and Farid and everybody, all the participants. Thank you all very much. Goodbye.
Thank you, sir. So thanks to John, Farid, and Sathi, and Dr. Mandan for your participation, and tell to all the participants. See you next week. Till then, stay safe.